Our next speaker is Elizabeth Eakin, who we're fortunate to have from the University of Queensland, who's going to be talking about public health programs. Where is she? There.
Thank you very much. I think that last talk definitely deserved a standing ovation, so that was a great idea. I'm happy to have one as well, by the way. Thank you so much for the opportunity to share some of the work that we're doing in this space in Australia. I can see why everyone has looked at this. It's not immediately obvious. The large one, green. Excellent. All right. So today what I'm going to be doing is talking to you about or comparing two different models for delivering healthy lifestyle support to cancer survivors. And they both involve collaboration with our cancer and public health partners in Australia. So to set the scene for them, both of them are telephone-delivered health or lifestyle coaching programs. And I'm not going to say a lot about the details because we've talked a lot about this type of program today. But both of them are free 6-month programs, and they're both based on the evidence base providing individualized support for healthy eating, physical activity, and weight management. And just so you know, they both are consistent with our evidence guidelines around healthy lifestyle. And they're both also consistent with what is now a fairly large evidence-based on-distance delivered programs for cancer survivors, including the really seminal work that Wendy DeMarc-Wanfried has been involved with. And Wendy, I just wanted to publicly acknowledge your support of the work that we've been doing in that space for the last 10 years as well, so thank you. Okay, so the two programs, and I'll build this a little bit, but I'm kind of giving you overview, and then we'll talk about each one, and then we'll compare outcomes. So one of the programs is cancer survivor specific, and in that program we're partnering with 4 of our different Australian state-based cancer councils, which be similar to the state-based offices of the American Cancer Society here. The second program is a general population program, so not developed specifically for cancer survivors at all. And here we're partnering with a state-based New South Wales Ministry of Health, which is like a state Department of Health, and also with a specific breast cancer clinic that's agreed to refer patients into this general population lifestyle program. So today what we're going to be looking at is comparing the two programs because we have some comparable outcomes across them. So we have some patient-reported and implementation outcomes, as well as some partner-reported outcomes. And I'm going to finish up by talking in a little bit more detail about the issue of screening. So the first program is our Healthy Living After Cancer program. It's funded by our National Health and Medical Research Council partnership project mechanism. And I put a little bit of detail here because it's such a fantastic mechanism for funding the type of partnerships that we're hearing more about today. So it is a dollar-for-dollar matching scheme. So basically, our National Medical Health and Research Council will match dollar for dollar both the cash and in-kind contribution provided by our partners. And there are, of course, stipulations around that, but that's largely the scheme. So it works wonderfully for this type of thing. Our partners are cancer councils located in 4 different Australian states. And in this project, what we're doing is integrating our evidence-based telephone health coaching program that's specifically for cancer survivors into an existing national cancer information and support service that's offered by our cancer councils across the country. Okay, so here is in very brief the protocol for this program, which is also being evaluated as part of a study. So patients can self-refer or be referred by clinicians into the program, and then they are screened and consented. They go through a brief pre-program assessment, which is over the telephone. They receive the 6-month program, and then they complete the same post-program assessment. The important thing here is that all of these activities take place in the context of each of the cancer councils. So part of what we've done as a project is to train and support the staff not only in the delivery but in the evaluation of the program. And just to briefly acknowledge our chief investigators, but probably more importantly for this audience, our associate investigators, which include Wendy and Katie and Carrie Cornea, who have all been very generous in providing their time and support for this project. The nice thing about this mechanism is we can also officially acknowledge as investigators our Cancer Council partners as well. And just a quick photo of some of the nurses and staff who are involved in delivering the program across the country. Okay, so that's the first program. Second program is called the Get Healthy service. Now here, what we're evaluating is the feasibility and acceptability of referring breast cancer survivors to this service. Okay, so this is a general population service. We're referring breast cancer survivors into it. And Karen, you nicely set this up in saying we don't actually have a lot of evidence about referrals of cancer survivors into general population services. So we've done this in a small way in the context of what we call the Get Healthy After Breast Cancer study. So our partners here are the health department that delivers this Get Healthy service, as well as the breast cancer clinic that is participating in the study and referring their patients in. And so I wanted to acknowledge just, the breast cancer physician in the study and her wonderful nurses. And it has been led by one of my postdocs, Shelley Lawler. Okay, so the brief protocol here is that within the nurse within the clinic briefly screens participants for eligibility, and that's just study eligibility. So you can see the criteria here, a very simple screening for the nurse to conduct. Eligible and willing patients are then referred on to us as study investigators. We conduct a pre-program assessment and then refer them on to the actual service, and then track them through their participation in the service to get a sense of how they went with the service, both qualitatively and quantitatively. And so this is just the Get Healthy service. So anyone in states in Australia where the service is offered can ring up and get access to this coaching, cancer survivors, people without cancer, et cetera. Okay, so the program comparison part then. We have common outcomes across both of the programs, as I said. Now, these are patient reported because what we're looking at are programs that are scalable, and so we have fairly minimal assessments that are feasible to conduct in practice. So we have patient reported weight, et cetera. We also have implementation outcomes that we're able to look at across the programs, uptake, completion, adverse outcomes, and then we have nurse feedback from both of the programs as well. So let's take a look at who took part. In our Healthy Living After Cancer program, it's still ongoing. So this is a snapshot of our first 300 participants. In the Get Healthy service, that study is completed. So we had 53 women with breast cancer who were referred in and took part in that general population service. So obviously, those were only women with breast cancer compared to a much wider patient group in the Healthy Living After Cancer study, although the vast majority are women with breast cancer as well. So you see high rates of female participation, similar in terms of age and BMI. Our folks in the Healthy Living After Cancer program are a bit farther out of their cancer diagnosis. Obviously, the women from the clinic are coming closer to their end of treatment. And then some slight differences in education and ethnicity. The breast cancer clinic that referred into the general population service serves a more diverse range of women with cancer. And so it was a really nice thing to have them participate here. Okay, so let's take a look at some of our patient-reported outcomes. What we have is the outcomes down the y-axis, where we've calculated standardized improvement from baseline, so we can kind of compare outcomes or magnitude of effect across the different outcomes. And then on the right, you can see the actual change in scale units. The purple is our Get Healthy service, so that's the general population service to which women with breast cancer were referred. And then the green is our Healthy Living After Cancer program. So, by and large here, we're seeing fairly comparable, small, modest outcomes, but on a population level or potential population level, some significant reductions in weight and concomitant changes in BMI, meaningful and reasonably large changes in physical activity, particularly for our cancer-specific program, and then some improvements in, albeit fairly crudely measured, a dietary measure of fruit and vegetable intake for our cancer-specific service, but not so for the general population service. And then if we look just lastly here at quality of life, we see opposite findings. So we see some improvement in the physical component scale for the cancer-specific service, and then the opposite, the improvement in the mental quality of life component for the general population service. So I won't go into detail about that here, but different findings. Okay, well, what about program implementation? Well, as you can see, once people were screened eligible, we have very high uptake rates across both programs. And amazingly, I couldn't have asked for this to come out any better, exactly similar completion rates across both programs as well. Those completion rates might look a little bit low for those of you who conduct randomized controlled trials, but for a free general population service, this is actually a bit better than what we often see. And importantly, no adverse outcomes reported across either program. All right, so I'll just share with you a little bit, because we've talked about patient voice being important, so a little bit of feedback from our patients here, from a woman who's taken part in our Healthy Living After Cancer study. Excuse me, I'm going really well since started the program. I've changed my life, gone from doing no exercise to walking every day. I feel so much better. I've dropped a couple of pant sizes and lost 5 kilos. My doctor is happy. And then from a woman who took part in the Get Healthy service, saying about her coach there, her calls have motivated me and kept me going. She was able to help me after my program when I found the going difficult. And we have lots of patient comments that reflect this kind of thing across both programs. But I guess the one thing I wanted to say, because I wasn't involved in doing these qualitative interviews, thank you. So I didn't get a chance to bias it in any way. But there was not one comment from the women with breast cancer referred into the general population service. There was not one comment from them about the fact that the service wasn't cancer specific, that their needs as a woman recently completing treatment for breast cancer, wasn't being catered to in the program, which after I pulled and pulled and pulled for the people who did the qualitative interviews, and surely there must have been one such comment, but no, there wasn't, which is quite interesting. Okay, one of our nurses who actually delivers the program in the Healthy Living After Cancer service took it upon herself to conduct a survey of all of the nurses delivering the service, which was wonderful because it was her really taking initiative in her own research, and it's been very valuable feedback for us. So these are our nurses in our cancer council, so they're cancer-trained nurses who are providing this Healthy Living After Cancer program. So lots of positives from them. They really like the application of coaching skills to other areas, because we talk a lot about this, but we did a 2-day training with the nurses to start, and we have ongoing booster trainings for them. So the motivational interviewing and other skills that they learned, they felt were quite applicable for them. They liked the increased knowledge of exercise and nutrition, which they felt they could apply not only across other areas of their cancer nursing practice, but a lot of them, and this reflects, I'm not sure if the woman from the oncology nursing, but were walking that talk in their own lives as well, which was just fantastic. But delivering the program for these nurses, now remember, these are nurses in our cancer information service, so they're used to providing a service that's just a one-off incoming call, bit of information and possibly some referral. In this program now, they have 6 months of continuous relationship with a person around health coaching. So a very, very different role for them. So it was challenging in terms of logistics, and it is a complex intervention, and there's evaluation around it as well. So there are a lot of things that were difficult for them. Many of them talked about switching their hat between this program and then the cancer information service, although some also really liked that, and that it broke up the monotony. And then also how they would deal with program participants' issues around depression and anxiety. All of these things were really valuable for us because we were able to address them in the yearly booster training sessions that we do for the nurses. Okay, so let's have some feedback from the nurses then from our breast cancer clinic who were referring their patients into this general population service. So here, remember, these nurses aren't the ones delivering the intervention, they're just doing the referrals. So an easy and positive program to discuss, and a good progression for patients after treatment. Some comments, though, about alternative programs, such as ones that are more breast cancer specific and group-based, might be better suited for some patients. And then they really liked incorporating the Get Healthy service referral into their breast cancer follow-up clinic, but felt that it might work best in a nurse-led rather than a doctor-led clinic in terms of the nurse's greater propensity to be involved in follow-up care. And I know you are here, but in Australia, we're having lots of discussions about shared care and nurse-led models and other ways of delivering follow-up care to our growing numbers of cancer survivors who are already far outstripping the ability of oncology providers to service them. Okay, so some take-home messages here before I switch just to finish up and talk a little bit more about screening. Really, I think despite some odd results around quality of life, we've seen remarkably similar outcomes across this cancer-specific and general population program, which small scale and small numbers, but to me suggests that both types of programs can be safe and effective when appropriate screening is conducted. I think, kind of as I have just said, basically both programs are really going to be necessary to address the health promotion needs of a growing population of survivors. And it's our partnerships here with state health and partnerships with our cancer councils that really made possible this successful delivery and are going to be a key part of any ongoing delivery. But I think we can definitely take a page out of what's happening with the YMCAs and look at further advocacy, because funding to carry forward will be an issue. Okay, so I'm going to finish up by talking about the screening issue. And I feel like I'm probably doing this. Catherine and I have had some extended discussion. She came over to our cancer survivorship conference just a couple of weeks ago in Australia, and we've had many discussions about screening. We've heard about screening here today. I am not here with the answers, but just to share with you a little bit more detail about what we did for screening that worked in the context of both of these programs/studies. So in our Healthy Living After Cancer program, the screening is conducted by either the Cancer Council nurse or even a research assistant in each one of the cancer councils. It's done over the telephone. We've trained up the nurses or staff in a very detailed protocol, so there's a detailed script that they go through. And I think the important part here is that any questions that are encountered in this screening process are directed in the first instance to an oncologist chief investigator in each one of those states. So we have an oncologist who's very generous with their time and very quick to respond in each one of our states. If there's a question, the email comes to us as the research center and then goes off to the oncologist, who always gets back to us within 24 hours. If we can't resolve the issue that way, if the patient is not a definite exclusion, then we refer them back to their healthcare provider for further assessment about their eligibility. So we do everything we can, given that these are population-based programs, to err on the side of being inclusive in a safe way. So these are our screening criteria there. We adapted them from Wendy's trials and protocols many years ago. These are the same ones we use as screening criteria in our survivor trials. So there's probably nothing really that would be surprising here. The main issue, of course, is about screening for the contraindications to unsupervised physical activity. Now, I'm not sure you're going to be able to see this next one. Not very well, and I'm sorry, but this is actually the protocol paper at the bottom contains this. But what I basically wanted to show you is that on the left side is the eligibility criteria, and on the right side is literally the scripted questions that the staff use to assess that issue. And if there are any questions, it gets immediately referred on. So they're never in a position of making any medical decisions about eligibility. Okay, so that's our cancer-specific program. In the general population program, the Get Healthy service, the way they do screening there, and not just for the cancer part of it, but for just the general population, is that there's a health professional form on the website. So if it's a primary care physician who's referring into the program, they fill out the form, the patient goes into the program, but patients or people can actually self-refer into this service. So if that's the case, then the coach from the service actually does the screening. So for our study, we wanted to try to replicate this process as much as possible. And so our research assistant used the same screening form that's there on the website that the health coach would normally use. And again, in this case, any questions encountered went immediately back to our breast cancer physician, who is the one whose clinic was referring into the study. And again, you can probably see that a little bit better, but this is literally just the screening and assessment form off the website. So screening criteria on the right, and then the kind of what to do with yes or no answers, where many of them here, a yes answer would lead to the person in our study case needing breast cancer physician approval, or in the general population case needing to go back to their primary care physician or other provider. But in both cases, for both our Healthy Living After Cancer program screening and this Get Healthy service with breast cancer, women with breast cancer being referred in, only 10% were screened as ineligible. So I think that in and of itself is quite telling. I think it also suggests that a lot of screening took place before women ever got to our official screening. Those who were sicker, et cetera, were screened out. But that's as you would want it in a population service anyway. So we're quite happy with this way this works, paired with the fact that we haven't seen any adverse outcomes across either program. Okay, and I'll just finish up with this triage model, which is really adapted from work published by my colleague Sandy Hayes, who's an exercise physiologist in Australia, as well as Catherine and Katie, where we've been talking about screening and triage. I know I'm out of time, so I won't talk through the model, but I think this is really our challenge, is to develop screening that can be used on a large scale, on a more population-wide basis that leads to appropriate triage and referral of patients to the type of program that they need. And Karen had some wonderful slides about that, so I will stop there.